Good evening, everyone. Oh my, does it feel so good to be in a room with people? Yay! And we couldn't have asked for a more spectacular autumn evening. It's warm, the colors, this facility is wonderful. It's really very, very nice to have all of you here. I know we have a number of people who are still joining us by Zoom. We welcome them as well. It's really amazing for me to see the support that we continue to have for the Women's Wellness Fund. Yay to all of you who have weathered us through this COVID 18-month crisis, which may still continue, but have stuck with us through all of our iterations of various meetings. But it's really nice to have all of you here tonight. For those of you who don't know me, my name's Laura Martino, and I'm one of the vice presidents at Middlesex Health. And we are so pleased tonight to have Dr. Hussain talking with us about our digestive health. I know that it's certainly an issue that affects many, many, many women. And it's actually, Dr. Hussain, you're our first male speaker. So don't be intimidated, but we love you. And I wouldn't have had it any other way. So we are so pleased to have you here tonight. I want to thank our generous sponsors this evening. Let me just try and advance this slide. It's not moving. Hold on one second.
Sorry. There we go.
There we go. I want to thank our generous sponsors tonight, the Peach Pit Foundation, Whole Logic, and Essex Savings Bank. They fully understand what the Women's Wellness Fund is trying to do, and we so appreciate their support. The Women's Wellness Fund advocates for, educates about, and funds priority women's health projects in our community. And we are so pleased that the fund has brought so many women together from throughout our community, east of the river, down south, up north, from everywhere. And so we're glad to have you here. Our steering committee is an integral part of the work that we do. We meet with them on a regular basis. They help us set agenda, set plans for the coming year, help us decide on funding priorities. Their names are here. If you're in the audience, please stand up and be recognized because we really do appreciate your support. And I know you're out there, so stand up. Great. I also want to thank the members of the Women's Wellness Fund whose donations are funding important women's health programs in our community. Since 2017, our members have donated more than $217,000 for women's health projects. That's a lot in the short time that we've had our group together, so congratulations. At this time, I'd like to invite Sarah Moore, our Director of Development, to tell you a little bit more about membership and what your donations are helping to fund. I hope you enjoy the program.
Thank you so much, Laura, and welcome to our Zoom audience. We know you're out there, although we can't see you, and we have about 40 people here in attendance in person, and we hope that those on Zoom can join us again soon. This is the total that we've raised since 2017 that Laura mentioned, and I'm just going to quickly say what we're funding this year with your member dollars, and we've almost met our goal, so I'm excited to share that. So we are upgrading a couple of projects in the Pregnancy and Birth Center. First, infant incubators, we're replacing all 8 of them and adding hospital-grade breastfeeding pillows. We're doing that because women used to bring their own, and that's not necessarily a great idea during COVID. So we have ones that can be sanitized in between use. So you helped us purchase those. So the goal there is just over $20,000. The next project is new technology to help with breast cancer surgery. And this is as opposed to wire localization of a tumor. You may have heard of that. This uses radar, and it uses a very small seed that the radiologist places, and then the surgeon can go back and find during surgery. It can be done not on the same day of surgery. It's less uncomfortable for the patient. And it improves the recovery time and has fewer side effects. So we already have that in place. I think we've done about 10 cases with it. So we're really excited that we've met that goal and we were able to fund that project. We're also funding a second round of a health equity study that the Middlesex County NAACP leads. We funded phase 1. We were one of many funders, and we're helping to fund phase 2, this time focused on Latinx, Latina, Latino health. We are funding the Latina health focus groups. And so we have funded that. So thank you so much. And then finally, this is a project that we fund every year. It's the fancy name is the Perinatal Social Work Program. And what that means is between 80 and 90 women get referred to this social worker. It's not a service that's covered by insurance. It's covered by donations like yours, and helps those women who are struggling, often with domestic violence situations, perhaps homelessness, and just poverty, connect to resources that are available to them, but they may not know how to access. And so that's a vital service. It helps women have, our measure is the March of Dimes recommended birth weight, and that's our measure of success. And 99% of the women who go through this program have a healthy delivery. So our goal this year is to raise about $45,000. We're at $37,000, so we're a little shy of our goal, but we appreciate everyone who's already given this year and those of you who are renewing throughout the rest of the year. So thank you so much. And those of you who are joining maybe for the first time. So if you are interested in membership, it's $100 or more per year. We invite you to 3 health talks like this, usually exclusively in person with a lovely meal, a glass of wine, and camaraderie to start the evening. And then you can always bring a first-time guest with you each time you come. And then you get to direct where you want your donations to go. Most people say all of the above because it's hard to choose between the great projects that our committee helps us select. And you can always do this online or check out a little bit more about the fund if you're not familiar with it. So this is the website. I'm going to jump into just a reminder for the Zoom audience. This is a webinar format, so you use the Q&A icon to ask any questions. And at the end of the talk, we'll take questions from all of you here in person and those of you on Zoom. So I'm going to introduce our esteemed speaker for tonight, Dr. Nadine Hussein. He's a fellowship-trained gastroenterologist. He has a lot of special interests. They were so numerous that we had to cut the list short, but a few of the highlights are GERD, GI tract cancer prevention, C. difficile infection. He has some incredibly interesting remedies and treatments for that. I don't know if he'll get into it tonight. Obesity and nutrition, IBD, etc. He serves as the medical director of the Middlesex Health Center for Digestive Health, and he'll talk about what that is. So he does his fellowships at a number of different institutions, Georgetown and the National Institutes of Health. He did residencies in internal medicine and surgery, I believe, at Washington Hospital Center and Wright State University. He got his medical degree from Jefferson Medical College. He started his clinical experience in the U.S. Air Force, and he practices with Middlesex Gastroenterology Associates. He's been there since 2005. So I'm going to turn the program over to Dr. Hussein.
Thanks so much for having me, everyone. It's an honor to be here, the first male. So today's topic is entitled Gut Check, what women need to know about their digestive health and gender differences involving common digestive disorders. So one thing we don't realize a lot is that there's a big difference between men and women. And in digestive disorders, that holds true also. And that starts from the prevalence of different types of diseases, the pathogenesis, even at the molecular level, and the symptoms patients will present with, and even the treatments that are rendered and the long-term prognosis. So there are big differences, and I thought I'd give you a flavor of what those are. So first, let's talk about prevalence. So the differences between men and women in certain diseases. So most of the functional GI disorders, there's patterns that we see, and the ones that are listed here, females tend to have more predominance of these disorders compared to males. So from the top of the chart, we can kind of look through here. So this is functional dyspepsia. The next is irritable bowel syndrome, and then the next is chronic constipation and chronic diarrhea and functional abdominal pain and fibromyalgia and then migraine. So you can see that overall the prevalence is much more significant in females versus males. And then even within the female gender, there can be differences. So even though irritable bowel syndrome with constipation is such a common problem, and same with diarrhea, constipation tends to be more common compared to diarrhea. And bloating tends to be more common in women versus men, and functional dyspepsia, irritable bowel syndrome, and chronic diarrhea are more common in women versus men. And then if within the female gender, anxiety tends to be more prevalent versus depression. So if we kind of realize the link there and the fact that anxiety correlates better with irritable bowel syndrome in women than men, sometimes if we focus on correcting the anxiety part of things, then we may be able to help with the cramping and abdominal pain type symptoms that the patients are experiencing. And then fortunately, in the female gender, at least pain is more socially acceptable. So at least you know that your doctor will believe you and help you with the discomfort that you're having, more likely compared to a male, which is unfortunate. So even from the standpoint of obesity, within women, there happens to be a higher prevalence of severe obesity. And then fortunately, as far as reflux-related complications in women, they tend to be less significant. So a lower risk of developing cancer within the esophagus and a lower risk of developing complications such as Barrett's or a stricturing. So that could give people some peace of mind. In women, when they develop fatty tissue within the liver and there might be surrounding inflammation and scarring related to that problem, weight loss happens to be more effective in women in treating that problem. So we could potentially reverse or at least stabilize the inflammation that's going on in the liver, recognizing that. And fortunately in women, that gender is more willing to commit to dieting or maybe even consider bariatric surgery. And even in that group, the risk of complications related to bariatric surgery tends to be lower. So there's a lot of positive things about this group. Gallstone disease tends to be more common in women. So that's why a lot of times you'll hear in obesity, especially obese women could develop gallstones, especially if they end up having bariatric surgery, then that kind of increases the risk even more. So that's something we just want to be prepared for and treat the problem if it occurs. So now let's review some pathogenesis differences between the two genders. So you probably notice in women, there tends to be a slower gastric emptying, and that's why a lot of times you'll notice that his stomach gets full quickly and then, kind of smaller meal plates. It's kind of a difference that I think people kind of appreciate. And then the other motility issue is that colonic transit tends to be slower. So
we just for those online, we got in the room, we disconnected from the screen. Did that work?
Oh yeah, great. I didn't touch anything, but now we're back online. So, all right. So in women, gastric emptying is slower, and colonic transit tends to be slower. So that's why there tends to be increased incidence of constipation. Yes, we have a question in the back.
Just when you words like this, whatever, NAFL, could you just explain what those are?
Oh yes. So that stands for non-alcoholic fatty liver disease. So it just basically means if there's fatty tissue within the liver, if there's an alcohol history, then we need to attribute it to that because alcohol can cause the same type of problem. So that's why they call it non-alcoholic fatty liver disease, because you've pretty much excluded that there's minimal or no use of alcohol. So the fatty tissue and the scarring and the inflammation is more related to obesity or weight gain or bariatric surgery. Those things can cause those type of changes to develop within the liver. So we want to kind of separate the alcoholic fatty liver disease population from those that are not alcohol related. Oh, dyspepsia. So yeah, the functional dyspepsia, that means that there's basically heartburn. So if there's acid climbing up into the esophagus or, but the reason they call it functional dyspepsia is because different people present differently. So they could notice heartburn, or they could notice that there's fluid climbing up the esophagus, or they'll notice chest discomfort. So it can present so many different ways, and that's why they kind of call it a broad category of functional dyspepsia. Great question. I'm glad, and I'll try to clarify that for the future. So in this diagram here, you could also see, and it kind of doesn't magnify really well up on the screen here, but in men, there are certain parts of the brain that will kind of produce more hormones versus women. So that's why there's differences both in the brain and at the molecular level that kind of have a downstream effect. And that can affect the emptying from the stomach, the emptying from the colon, and that's what kind of leads to these differences here.
I'm not sure why that keeps happening. I think there is a spotty Wi-Fi connection. And I think that's just what we're struggling with. There we go.
Okay, great. So just for those online, I'll just mention there's a little bit of a Wi-Fi issue, and that's why we're losing our connection once in a while. But we'll make sure to connect back. So now I'll review the gender differences with obesity. So there's metabolic differences between men and women. So men are pictured on the left, and women are pictured on the right. And this could be related to organs. So for example, brown adipose tissue tends to be more prominent in women and lower mass and activity within men. White adipose tissue, that tends to be kind of more prominent in the hips in women versus in men. It tends to be more centrally located, contributing to the central obesity that we might see in men with aging. And then there's changes that occur at the molecular level. So in women, there's decreased muscle mass, increased leptin, increased subcutaneous fatty distribution. And this leads to the different degrees of pathology in men and women. And here in women, there's an increased incidence of impaired glucose tolerance, which means that they're having more difficulty processing sugar, and that might lead to conditions like diabetes. And then there's the increased incidence of obesity and increased incidence of visceral adiposity, which means collection of fatty tissue within different organs. And that can include organs such as the liver or the pancreas, and that can affect the function of those type of organs. So someone might not produce as many enzymes from their pancreas and might have more trouble digesting food or having diarrhea. So that's why those things can make a difference in the long run from the symptom standpoint. Which brings us to symptoms. So from the symptom standpoint, we'll go through some differences between men and women here. So in women, there tends to be a greater chemical esophageal sensitivity. So for a smaller degree of acid climbing up into the esophagus, that can end up causing more discomfort in women versus men. And we can see that in different ways. So for example, when we measure how much reflux is occurring during a 96-hour period by placing a capsule at the esophagus and measuring with normal meals and eating and going to sleep how much acid's climbing up in the esophagus, we notice in women the percent of time that, oh yeah, no problem, I'll just reconnect there. Yeah, no worries, yeah. So, so in women, the percentage of time that the acid climbs up in the esophagus tends to be lower overall versus men. And the reflux episodes are shorter. But then the difference is that there's a higher chemical type pain and the referred areas are greater. So that's part of what can make it confusing. In someone, if they have reflux, and then with that, if they develop chest discomfort, we don't know for sure. Is it related to acid reflux, or could it be some other reason? Could there be cardiac issues, or could there be some other etiology behind the pain, such as muscles or bones being affected? And so we have to kind of do some detective work and try to figure out what exactly is going on there. And then in women, the contractile duration within the esophagus, so how much it's contracting with swallowing or just normal function, it's a longer contraction duration. And that can affect things. And that's something we can look at with motility testing and see what's going on functional-wise within the patient. And then the esophageal sphincter, that's the valve that kind of keeps fluid and food from climbing up into the esophagus. That's actually kind of a shorter length in women versus men. And with age, we see that it kind of degrades over time. So the strength of that muscle, if it gets weaker, then it becomes more likely that patients could experience reflux-related symptoms. So now let's talk about earlier satiety. So that's that condition where you could feel full quickly. So having a small meal and then all of a sudden you're full and you don't feel like eating anymore. And that can be due to a number of different factors. That involves slower emptying from the stomach, and then that sensation of being full quicker. And then there's a lower maximal acid output within the stomach, so that kind of affects the digestion of food. So the food is being digested slower. And then there's decreased contractility within the antrum, so the lower part of the stomach is contracting less. So that takes longer for the stomach to empty out into the small intestine. So all those things put together, especially if one of those problems is pathogenic, where it's pathologic, where it's beyond the normal range, then it ends up causing more symptoms and more trouble. So another way where symptoms can be different between men and women is in inflammatory bowel disease. So in this group, women end up having overall lower quality of life scores versus men, and this has to do with all kinds of different things, including body image. Okay. Hello? Oh, yeah. Okay, great. Okay. Oh, no, not at all. So body image is one factor that can affect why women have lower quality of life scores versus men. And there's other problems too. You know, with the immunosuppressants that are used in conditions like Crohn's disease and ulcerative colitis, they can affect the risk of developing cervical cancer, and they need to undergo regular screening through the gynecologist. The inflammatory bowel disease can cycle with menstrual cycles. And then the symptoms can worsen before and during menstruation, so that can affect things. And then from the body image standpoint, between whether there's active disease. So, for example, if there's active inflammatory bowel disease, such as Crohn's disease, there could be associated weight loss problems or problems with hair loss, and that can affect the body image. Or there might be sores or bumps on the skin, and that can occur with Crohn's and ulcerative colitis. Or there might be fistulas or arthritic symptoms. It can make someone so disabled that it's kind of affecting their day-to-day, and that's affecting sexual function and everything else in their life. And then there's the whole category of medication side effects, where patients can experience weight gain, hair growth, acne, hair loss, even psoriasis from the medication. So the medication might be helping the Crohn's disease and the bowel is healed, but then they start developing these rashes on the skin. So we have to kind of figure out a balance of helping the disease itself, but then trying to help the body image also. So in some cases, we might even have to switch the agent that we're using to try to treat the Crohn's.
I can just describe the difference between IBD and Crohn's.
Oh, sure. So yes. So we have a great question from the audience here, and that is, what is the difference between IBD and Crohn's? So IBD is a category of inflammatory bowel disease that includes Crohn's and ulcerative colitis, and then there's some conditions where there's inflammation within the colon or the small intestine, where it's not clear whether it's Crohn's or ulcerative colitis, or if there might be some other cause behind the inflammation. So the term IBD, or inflammatory bowel disease, kind of covers that whole group of patients. So fistulas are those tiny little openings that people get on the skin, where it can go from the skin to the intestine, and that is a problem that tends to occur more with a condition like Crohn's, whereas ulcerative colitis tends to have less of an issue with that type of problem. So great question. Thanks for that. So now the other situation where there's a difference in symptoms is that skin and gallbladder issues tend to be more common in women associated with inflammatory bowel disease. So, but the one good point in the female gender is that the females tend to have the condition called primary sclerosing cholangitis much less than men. So in men who have inflammatory bowel disease, they have a higher risk of developing that condition, where there's scarring and narrowing within the bile ducts. And that can be a pretty serious condition where it can lead to liver transplant eventually. But fortunately, overall, it's kind of a less common type of problem. And then in women, like we mentioned, there's a higher likelihood of skin conditions and gallbladder issues, especially relating to inflammatory bowel disease. And then there's altered fertility and effects on sexual health. So we have to take all those things into account. And then even hormone use, that can be affected by which types of agents we're using. So we want to make sure that we're not using a medication that is affecting their contraception, or we may want to make sure that the contraception is working, because some of the medications can have issues with pregnancy. So it kind of gets a little complicated with all those mixture of things. And then I'll go on to therapy differences between men and women here. So therapeutic differences. So in women, this group tends to be more likely to undergo anti-reflux surgery in the United States. And this could be related to a number of factors, and part of it could be related to the increased sensitivity to even smaller amounts of acid reflux causing troubles. And they tend to respond well to anti-reflux surgery, and that's something we've been kind of helping work up and get them to the appropriate surgeon to be able to get those type of treatments. And then in women, they tend to respond better to medications like metoclopramide, which is a medication that will help stomach emptying. Um, but in women, they respond better to intranasal formations of that medication compared to the normal oral form of the medication that we would use in most people. But in the female gender, they would respond better to that medication. Unfortunately, there is a risk of side effects with medications like that, and that risk of side effects tends to be higher in women. But if we use it intranasally, then there's lower levels of that drug, and that's why it tends to be a better choice. Pyloric and Botox injection is an option where in the lower part of the stomach, the muscle where there's a sphincter there, that can be injected to help relax the stomach better, so the stomach can empty better, and that way there's not that feeling of early satiety that we had talked about. But in women, a higher dose needs to be used to try to help with that problem, to be able to achieve better results there. And then for that issue that we talked about, functional dyspepsia, which basically means heartburn, regurgitation, pain, or chest pain related to reflux, that tends to respond to medications such as amitriptyline. And fortunately, that works equally well in females and males. So that's a nice plus. So that kind of makes it a little bit simpler. But you know, in conditions such as irritable bowel syndrome with diarrhea, and that's irritable bowel syndrome. Maybe I should just summarize what that is. It's a condition where we don't know of any active ulceration or stricturing within the intestine. So the patient's gone through a full workup, and we don't identify any problems such as Crohn's or ulcerative colitis or microscopic colitis, different conditions that can cause diarrhea, and they're suffering with symptoms such as cramping and diarrhea, and the symptoms seem to resolve following a bowel movement. So there's specific criteria. If they fall into that group, then we can call it irritable bowel syndrome with diarrhea. And in women, there are certain medicines like remosatron that tends to be effective at half the dose compared to men. So we have to kind of realize those differences there. And then for irritable bowel syndrome with diarrhea, there's also a medication called elocitron, and that tends to be more effective in women compared to men. And for irritable bowel syndrome with constipation, where patients tend to have similar symptoms, cramping, abdominal pain, but they tend to lean more toward constipation. This medication called prucalopride that works equally well in both genders. So now let's go through prognosis differences between the two genders. So if we look at liver disease in men versus women, there are some differences that we want to keep in mind. So in women, there tends to be overall lower incidence of hepatitis B, hepatitis C, alcohol use and abuse compared to men, even though there is a high degree of use still. But and that's one of the reasons why cirrhosis tends to be less frequent in women versus men. And then in women, the most common causes for cirrhosis include viral infection, such as hepatitis C, but a very common cause in women is autoimmune cirrhosis, which is much less common in men. And this is a condition where the body is kind of fighting itself, kind of almost treating the liver as if it's a foreign body, and then attacking it with antibodies and causing inflammation within the liver, and that ends up causing scar tissue and inflammation. And if that goes on for too long and it's untreated, then scarring can develop and cirrhosis ends up developing. So cirrhosis basically means there's so much scar tissue in the liver that it's affecting things downstream. So the spleen gets enlarged, blood vessels can grow within the esophagus, there can be bleeding issues, So we want to try to catch things before it reaches that far. And there's ways to do that. So we can try to stay ahead of that. And then the other interesting thing is in women, in the premenopausal state, fibrosis progression tends to be slower. But then after menopause, then it kind of starts equalizing with men. So that's why we kind of see a lower incidence of cirrhosis in women, especially premenopausal. But then after menopause, then it kind of starts to equalize. And then also in women, there's a lower risk of developing liver cancer. And one of the biggest risk factors for developing liver cancer happens to be scar tissue within the liver. So less cirrhosis in women and less liver cancer in women for that reason, because you have to have scar tissue in the liver for a long time before it puts you at risk for developing liver cancer. So, and then pregnancy in women with cirrhosis is rare since it affects fertility, and it's discouraged also because there is a higher risk of complications. So once it's reached that point, then it may be something to avoid. So that's something we want to warn patients about. And then, as we mentioned before, there is a big difference as far as autoimmune inflammation within women versus men, whereas that is one of the common causes for cirrhosis in women, versus in men it's kind of much less common. And then in the group awaiting transplant, as far as scar tissue within the liver, viral hepatitis tends to be the most common, and then in women, autoimmune disease is also very common there. Whereas in both men and women, there tends to be a higher prevalence of non-alcoholic fatty liver disease, and that kind of goes along with the high incidence of obesity in this country, and it's been trending upward, and that's been affecting things in the long run as far as liver health. As far as the liver goes, one thing you want to remember is that women tend to be more sensitive to alcohol versus men. So a woman having 2 drinks of alcohol could affect the liver more than a man having 2 drinks of alcohol, and that has to do with how quickly it's metabolized within the liver. And then we talked about menopause affecting the progression to cirrhosis. So to summarize, there's big differences between the 2 genders, and this starts from the beginning, between the prevalence of diseases, the way the diseases started in the first place, the type of symptoms patients will present with, and the type of treatments we want to offer, and also what the prognosis might be depending on the condition. And much is still not understood about the differences between the 2 genders. As you might have seen in the tables there were a lot of things that still are under study, and there's no conclusions about certain medications for treatment of certain diseases, or what the molecular changes are in different conditions. So more study and involvement in clinical trials is needed, and prospective trials involving more women would help fill gaps in this knowledge. And I think that's been happening more and more, especially over the past 10 years. So I think as time goes on, then we'll be able to identify more things that we need to pay attention to, which brings us to the third point. So clinicians need to be extra attentive for gender differences during evaluation, management, and prognostication. So at this point, I want to introduce Stacy and Shayna, who are very involved with the Center for Digestive Health, and they're part of the core team for the Center for Digestive Health. And maybe I should just kind of briefly summarize what that program is about. So there's so many things that we've been involved with, and over the past year and a half, we've been developing programs and Now we have a collection of about 500 patients that we're actively following between the cancer patients and patients with digestive disorders that need multidisciplinary help. And that can be between the surgeons, the psychiatrists, oncology, the behavioral medicine folks, even acupuncture. It differs depending on the condition. So for example, there's a few here. So from the reflux program standpoint, we might see a patient who's been having chest discomfort, and we might need to get them in touch with the cardiologist, make sure it's not a cardiac issue, depending on the way the symptoms are presenting. And then there's ways to measure how much reflux is going on, what exactly is going on with their esophagus, are the muscles working correctly? And then in the right condition, if there's a hernia present, then we'd get them in touch with the surgeon who'd be able to offer the appropriate treatment options to be able to treat the condition. And similar for obesity, where we find somebody who's having difficulty with weight. So we want to identify what the problem is, whether it's diet or exercise issues, or whether it's an underlying metabolic problem. And there's medications that can help with that. And if they reach a point where the medication alone is not good enough, there's surgeries that can be done to help with weight loss. So we've seen tremendous success with those programs also. And liver disease is another protocol that we've just recently developed. And now the hospital is doing fibroscans and MRI elastography, and that can save the patient from having to undergo a liver biopsy. And we can get a good idea of the full liver and see if there's any sign of scarring within the liver without them having to undergo a liver biopsy. And there's cutting edge viral hepatitis treatments these days. For example, with hepatitis C, for most types of hepatitis C, they're divided into genotypes, depending on from what country they came from or whatnot, and that can be determined by blood testing. The treatments these days are in the range of 99 to 100% effective. So we've really come a long way. And even from the standpoint of liver tumors, if we identify a tumor early enough, and if we know that someone's at risk, then we can screen them carefully, identify that there's a tumor developing, and our radiologist can treat that effectively even at the newborn stage. Basically, if there's like a 1 centimeter tumor, then it can be treated through radiology, where they'll insert a needle and then apply either chemotherapy or radiation and be able to treat that tumor without the patient having to undergo major surgery. And then there's other major programs too. The C. diff program, where we're using targeted antibiotics and then human monoclonal antibodies for patients who have refractory C. diff. And if they've failed 2 or 3 treatments and they keep developing infection within their gut, then that's something we can treat with stool transplantation, and that's been a tremendous success. The success is a big difference compared to what we had before. Between the antibiotics, they might be effective, in this case, maybe 20% of the time, whereas one treatment with colonoscopy and stool transplant, we will have success rates in the range of 93%. So it's so dramatic that it makes a huge difference for patients. And then inflammatory bowel disease, we have this collaboration with the Mayo Clinic, and for complicated cases, we can run the imaging, pathology, everything through the experts up there and see if there's anything that they would fine-tune, especially for someone who's failed 3 types of biologics. And when it gets really complicated, it's helpful to have that type of expert input. So that way our patients know that they're really getting the top-notch expert care. And they don't even have to make a trip out to Mayo Clinic. They can get all that input from there. And then the last topic is GI cancer. So GI cancers, we've been trying to kind of really streamline the approach there. So either screening for GI cancers, or when it's identified, whether it's tumors within the pancreas or colon, stomach, we want to do the appropriate genetic testing, make sure they get to the surgeon, the oncologist. So we're doing all kinds of things to make it rapid and smooth and make it very easy for our patients, some of them who might be elderly and have many other medical issues too. So I'll hand it over to Stacy now. I know she was going to introduce herself.
Hi, everyone. Thank you, Dr. Hussain, for presenting. So I'm Stacy Dodone. I'm the nurse navigator for the Middlesex Center for Digestive Health. As the nurse navigator, I act in as the hub, essentially, for our program. So all referrals are triaged through me directly. And then I help to connect all the dots of our program, whether that's helping get the patient from the gastroenterologist over to the colorectal surgeon, GERD surgeon, or other supportive services like the nutritionist, behavioral health therapy, or integrative medicine services like acupuncture, massage, and I also collaborate with Shayna.
Like you.
Hi, I'm Shayna Prue. I'm the head, neck, and GI nurse navigator for the Cancer Center, but I also collaborate with Stacy for the Center for Digestive Health. We really work together to follow high-risk GI patients to make sure if they need any workup, like Stacy said, with supportive services, imaging, go throughout the Middlesex healthcare system. We help to expedite that and make sure it's really scheduled in a timely manner.
Oh yes. So yeah. So thanks guys for introducing yourself, and then now I think we're going to address the questions, right? Or should,
Yeah,
yeah.
that's great.
Okay. Great.
I have one from a home viewer. What are the advancements in treating pancreatic cancer?
Great. So the question from online is, what are the advances in treatment of pancreatic cancer? So there's a large study going on through the United States, and Yale is actually part of that program, where they're actually looking at the markers within the pancreatic juices to see if that's something that we can do to be able to detect pancreatic cancer early. So that's one of the active clinical trials that is undergoing, and it looks very promising. In fact, there's ways to detect markers even within the stool and on blood testing, but that's considered experimental at this point. Right now, they're kind of really looking forward and following patients really closely to be able to get that data. But what we've been doing over the past several years at Middlesex is we've been following these patients closely. So between the genetic testing, identifying patients who are high risk, and following those patients closely with the MRI imaging, which we have one of the most advanced scanners at both the Westbrook Center and at Middlesex in Middletown. So we're able to see a great deal of detail within the pancreas, and there's ways to highlight parts of the pancreas with oral and IV contrast, so we can see detail really well. So what works best is following with the MRI imaging, but also following with endoscopic ultrasound. So that's a procedure where a scope is passed, similar to an endoscopy, but the scope is passed through the mouth into the esophagus, into the stomach, and using ultrasound from the inside, we're immediately adjacent to the pancreas, so we can see the detail within the pancreas very well. So with that, we could identify cysts or precancerous lesions that we might be able to take fluid from and send it for DNA testing and identify cancer that could be developing or potentially developing, or even if there is a cancer there, identify the tumors early so that we can treat with surgery. And we do have a very qualified pancreatic surgeon who's been doing excellent work. And in fact, just yesterday I saw this patient back where I had identified a neuroendocrine tumor within the pancreas about 6 months ago, and she had surgery and she's doing very well. It was a stage 2 pancreatic cancer neuroendocrine tumor. She didn't require any chemotherapy, and she is so grateful for the intervention. So I think we are making big strides, and I think there's more to come. Okay, sorry.
Can I just add something? I just wanted to add too, Stacy and I, as part of the Center for Digestive Health, we do track incidental pancreatic findings that come through our emergency room. Any abnormal imaging, Stacy and I get notified, and we send a letter is sent to the primary care office of that patient, and we get the ball rolling to ensure that the workup is scheduled too. So we also track all incidental findings as well.
Now that you scared us all, what do we do for, like, one question I have is about probiotics, and the second thing is, some friends are doctors, and they're like, oh, if they don't eat done, so what would be your 3 wishes that you would say to us to prevent us from wanting to come visit you? So what can we do to improve our guts? I know you can say no alcohol, weight, but there are other things that the advertisements for probiotics, are they myth or just the probiotics?
Great question. So let me summarize just for the folks online. So the question is, what are general pieces of advice that could be helpful, including probiotics and lifestyle measures that might make a difference in the long run, health-wise? And we were just talking about pancreatic cancer. For example, the #1 reason why people develop pancreatic cancer is smoking. Smoking ends up revving the risk for cancers within the GI tract. So that's probably the #1 thing that would be ideal to avoid. The other thing is alcohol in small amounts. It can be healthy for the liver and may not necessarily be bad, but larger amounts that can start developing toxic changes within the liver and the pancreas. So we want to kind of be aware of that. And then eating real food is probably one of the most important things. So whenever possible, preparing your own food and preparing food from scratch, having less preservatives. I'd say those 3 things are probably the simplest and probably, and then staying active. Exercise is probably the best drug because it's one of those things that can treat almost everything without any significant side effects, except for a muscle ache or something, So, and then the probiotic question, so there's so many probiotics in the market these days, and there's some that are focused on digestive diseases. So for example, there's Align, and then there's Culturelle, and then there's a new one called Envive. And my advice to people is, depending on if they have issues such as irritable bowel syndrome, there is evidence that probiotics can make a difference. So by rebalancing the type of bacteria, it can make a change there. Some of those medications end up being expensive, where it could cost $1 or $2 per day. So it ends up adding up over time. So even a generic probiotic, which is multi-strain, could be helpful. But I'd say the key is eating healthy and having fiber in the diet, because the fiber itself can rebalance the type of bacteria in your gut. So that may work just as well as taking a probiotic over the counter. Great question.
Can I just, with the probiotics, I mean, probiotics through food or through, that, rather than popping a pill, you probably best with probiotics through the food, or were you talking about gut health and your microbiome to do fermented foods or what have you? What do you think about that?
Oh yeah, that's exactly. So so from the audience, there was a good point that from food you could really balance the probiotics in your system. So for example, fermented like cabbage might be a good example of that, or pickles, sauerkraut, yes, yeah, kimchi. So that's a great approach. So that way, without medication, you could try to achieve the same results. So I think it's a test and trial, and you just have to see if it's working well for you and if it's helping you feel better overall. And keeping a diary can help, because that way you can compare week to week, month to month, how you're doing.
What would bring me to, or what are the signs and symptoms maybe of pancreatic cancer? It seems like it's already progressed so far with people discovering.
So yeah, great question. So the question is, what are the signs and symptoms of pancreatic cancer? And the problem that we run into is that the symptoms tend to be late, especially if there was a tumor that's not affecting the bile duct within the pancreas, and that tends to be in the head of the pancreas. So until the tumor is affecting that area, patients may not even realize that there was an issue. So that's when you might start developing weight loss or nausea or pain in the stomach. But we want to try to catch things earlier before they start having a yellow color to the skin. So in someone you're concerned about, for example, if there's a history of smoking, or there's that family history of pancreatic cancer, then we want to be extra aware. But it can be a little bit tricky because if someone has a family history of breast cancer and stomach cancer, that could put them at risk for pancreatic cancer. So what we're doing these days is any patient who comes in to the GI office, they'll be screened for their family history. So if there's any condition like melanoma or ovarian cancer history in the family, that could clue us in that maybe we need to do genetic testing, maybe we need to screen for pancreatic cancer. So it's a tricky situation, but if we proactively look for those things, then our hope is that we might be able to catch things before they cause trouble.
How do you screen for it? Blood? Blood test?
So there is a blood test. It's called a CA19-9. It's considered a tumor marker for pancreatic cancer, and that's something it's recommended to do that if you highly suspect pancreatic cancer. But really, the screening would be more MRI imaging, the endoscopic ultrasound, getting detailed images of the pancreas, seeing if there's any hint of problems with the pancreatic duct or if there's any sign of growth within portions of the pancreas that make it concerning for tumor. And we've really had a lot of success with that. We've found probably over the past 10 years, so many stage 1, stage 2 pancreatic cancers, and patients are doing really well, but then the stories you hear about are the ones that presented so late where they had pancreatic cancer and it spread to the liver. And unfortunately, it's not perfected because there's some patients who may not even have been seeing a primary care doctor or be lost to the system or traveling from state to state. So all those things kind of end up causing problems.
We're going to take one more. We have a good one online, and then we'll wrap up. And then I'm sure you'll stay a little while after for any personal questions you want to ask. Go ahead.
And our final question is, what is your best advice for maintaining regularity?
Okay, great. So we have an online question. This is the final question for the evening. And then, I'll be here to stay, so feel free anytime afterwards. So the question is, what is the best advice to maintain regularity? And that's a really tricky question because it's different for everyone, So depending on whether there's an anatomic issue or if there might be a tortuous colon, but I found that people can kind of gauge what they need, and usually we'll start with fiber supplementation. So either having extra fruit and vegetables in the diet or supplementing their diet with fiber such as psyllium fiber or other types of fiber. Psyllium tends to be more bulky, so it can have a side effect of bloating. So some patients have trouble with that. Or using herbal remedies like senna laxative teas. That could be kind of a gentle laxative that might be something to kind of make as a routine every evening, have a sip of herbal tea. or using laxatives as needed, such as Marilax or Delcalax, when needed, maybe every couple days or so. So I'm not sure if there's a perfect answer to that question, but and I think it's different for everyone, but they have to kind of test and trial and see what we could do right to make things better. And these days there's pharmaceutical type medications also if things are really reaching an extreme. So yeah. So thanks everybody. Really enjoyed.
All right. Thank you so much, Dr. Hussain. We kind of scratched the surface of this topic, so I know we might have to revisit it in future talks. Just a reminder, if you are interested in learning more about the Center for Digestive Health, you can go on our website, or if you wanted to reach out to our nurse navigator, this is the phone number. And it's in your programs for those of you who are in the audience. I know you can't see the screen. We had a technical snafu. And then finally, I just want to put a plug in. We do want your feedback. It's always helpful to get feedback about the specific talk that you attended, but also any recommendations you have for future talks. So the survey is online. We are eliminating paper. So it's middlesexhealth.org/Women's Fund Survey. So if you have a moment to fill that out, that would be great. It is listed in your program if you forget the link. And then finally, if you're considering becoming a member, if you need to renew your membership, we welcome everyone. We hope that you will consider becoming a member, and we will have 3 wonderful talks lined up for you next year, and perhaps they'll mostly be in person. The exciting thing is that because we have the technology of Zoom, we can always offer this hybrid option, and sometimes that's just easier for somebody. So I think we'll continue to do that, and we can easily record them as well. So thank you so much. Have a lovely night. It's lovely to see all of you. Thank you.